Yes, sir, ma'am. You can start now. Ma'am.
Yes.
So, Shruti, am I starting?
Yes, ma'am. You
Yeah.
can start.
Okay, fine. So, good evening, everyone. And it's a very honor and privilege for me to welcome each and everyone for this yet another episode of Fertilogix webinar series, which is the brainchild of our visionary leader, Dr. Archana Basir, ma'am. Ma'am's relentless commitment to advancing reproductive medicine has made this platform possible, and we are very much grateful for her guidance. We also extend our heartfelt thanks to each and every faculty, our guest of honor, our chief guest, respected chairpersons, panelists, and all brilliant faculties whose expertise will shape today's discussion. Their presence not only enriches this event but also underscores the importance of the topic we are tackling, that is the recurrent pregnancy losses. So, without much ado, let me request Shruti to start with the Saraswati Vandana and then we'll proceed with the session. Shruti, can we play? Shruti, can we play the Saraswati Vandana? Yeah.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Thank you, Shruti, and thank you, whole UNS team, to organize this webinar. Now, can I have the CV of Dr. Archana Basir, ma'am, please? Shruti, can we have the CVs, please? Shruti, am I audible?
Yes, you're audible, madam. I
Yes.
believe
Okay, yeah.
Shruti must be facing some technical challenges. I'm
Okay,
just
fine.
coordinating.
Okay.
Give us a
Yeah,
second.
Okay.
Bhakti, do you have the slides with you?
I mean, Rudri, you can just introduce me
Yes,
simply.
okay, fine. Yes, ma'am. So, sorry for the technical glitch.
Sir, I think
And
she's sharing some technical issues there.
yes. Okay, no problem. We will go ahead. So, I extend my heartiest welcome to Dr. Archana Basir, ma'am, who is the pioneering in this Fertilogix webinar series. And ma'am is a Foxy presidential candidate for the coming election year 2026. And ma'am is the director and a senior ART consultant for and director of Akash Hospital and IVF Center, Indore. We extend heartiest welcome to you, ma'am. And I request Archana Basir ma'am to kindly introduce our chief guest, Dr. Alka Pandey ma'am, and give a welcome note for ma'am.
Good evening, everyone. At the outset, let me thank all of you who have joined here and my all the gratitude to our Chief guest Dr. Alka Pandey, guest of honor Dr. Asha Bakshi, and our speaker Dr. Sachdeva, and our moderator Dr. Achal, all the panelists who are really sparing their time to join this webinar, and my conveners Dr. Rudri, Dr. Kalyani, and my dear Secretary of MP SR, Dr. Brajbala, and our chairpersons, Dr. Anjali Kanhare, and everyone who has really been giving their time for this webinar talking about the infertility. And really, I mean, we one side we are saying that we have a very large population, but other side we are facing the problem of infertility day in and day out. I think we really need to remain ourselves updated, and this is our endeavor to connect with all our specialists, fertility specialists, and spread the message that infertility is a problem and it needs to be tackled in time, and timely referral has to be done. So I'm with this, I would like to invite our chief guest, Dr. Alka Pandey, to the dais. Dr. Alka Pandey is known to me from so many years. I think we connected first with Dr. Alka Pandey in RCOG conference which we did at Indore, and I met her recently also in Patna. She's a very well liked and very loving in person, and she's ex-professor Obs and Gynae, Lord Buddha Koshi Medical College, Saharsa, past president Patna OBGYN Society, past president Foxy, a national corresponding editor of Jogi, and ICOG governing council member. Very, very active, very energetic and enthusiastic person. Over to you, Alkadi, for your kind words, advice, and words of wisdom on our webinar.
Thank you. Thank you very much, Dr. Archana, for giving me this opportunity. And I really congratulate you because you have selected a very, very important topic, that is recurrent pregnancy loss. And we all know that one after another fetal losses, yeah, pregnancy losses depresses the woman so much that it is really hard to bear. We are knowing about only 2 or 3 medicines which we are going on prescribing for APLA, low molecular weight heparin and ecosprin and Bharglobe and this and that. So we really want to know the updates. What are the updates for recurrent pregnancy loss? And you have selected a very, very good topic, Archana ji. Congratulations for that. And heartiest wishes for your coming Foxy elections. I really wish you good luck.
Thank you, Dr. Alka. Thank you so much. I think it's like very important, as you said, that what happens in the panel discussion, everybody brings their own inputs and what they are when it is especially case scenario based. So I'm sure we all will have a good learning today. So thank you for gracing the occasion and for your kind words, Alka ji. So now I would like to invite my dear friend and the stalwart of infertility in India, Dr. Asha Bakshi, whom I have known since I have joined the OBGYN in my medical college days, is one of the brilliant student of MGM, and she has really, gone so high. She's currently secretary of National ISAR, and she's member of Executive Committee AICC RCOG, founder chairperson of MP ISAR, member of Advisory Committee PCP NDT Indore. She has been vice president of Foxy, I think, along with Dr. Alkaji only, and she has held so many positions: Infertility Committee, ICOG Governing Council member, and lots of award to Dr. Asha Bakshi about the first ICSI, TISA ICSI, Micro TC, and she has organized conferences, Star Endogen Conference. She has been organizing chairperson of AICOG, which we did together in Indore, and organizing chairperson of VP conference in Indore in 2023. She has worn so many hats, and she is a very balanced person, academic, social, family, and everything. So over to you, Ashadi, for your constant support and your wisdom you give to us. And please give your input us on this webinar.
1 minute, I would like to interrupt. Asha, I'm a great fan of your everything, and I really admire you a lot. And a very, very good evening.
Thank you, Alkaji. So first of all, thank you, Archana. You are my one of friend in good and bad times, and everywhere we are remembered as three Bs. Though Kavita is not here today, but most of wherever we go, people remember us three Bs. So we have been together since long time, and I really wish that you come up in a big way, and your wish to that you are contesting for the presidential election that is going to fulfill, and you think I think you are a great candidate for it and you deserve it. So, and about Isar, I would like to say that Isar is doing great job under the presidency of Dr. Amit Patki, with more than 6,500 members and more than 24 state chapters. And recently, you all will get one communication that for the best state there is an award. So for that award, I wish that Madhya Pradesh applies, and I wish we get the award this time. So all of you should really apply. And regarding Alka Madam has been. She was my means when we were vice president with Dr. Rishikesh Pai. We were together, and a very humble, patient, intelligent, knowledgeable person, and a lot to learn from her. And she's very popular amongst people from Patna and otherwise all over India also. So a very warm welcome, Alka-ji. And I think MP Sar is doing very good work, especially Dr. Archana is supported by Dr. Brijbala and all the other members. And today you have really selected a very good topic. But before that, I would like to also thank the conveners, Dr. Kalyani and Dr. Rudri. Rudri is a very very active person and really working hard. And we can see that how quickly she's going to go up. And today the chairpersons are Rakhi Singh, who is a good friend. Puneet, she is a very good friend from we got to know each other from Amsterdam, a very knowledgeable person. And in that, in the boat, I think we sat and we discussed all infertility practice in the boat only. And we thought there was no point going in Ashray. We should all sit together and discuss our clinical problems. Anjali, again, she is a very active person from Bhopal. Then nice to see Shivani. Shivani will come up with lots of good points, and we will know about RPL. And then nice to see Achal. Achal also. Achal was with me again in Amsterdam during Ashray, and we had a great time together. And she's not only a very good practitioner in ART, but she's a very good singer also. And I've heard her how well she sang during the ISAR annual conference in Lucknow. And I'm sure today all these discussions will take us a long way, so that we do not just treat the patients empirically, but we really work and evaluate and give the targeted treatment rather than just give a blanket treatment. So wishing you all the best, and looking forward to very good interactive program. Thank you very much for inviting me, and all the best to Archana for her presidential candidate election. And at the same time, I wish MP Sar gets the award this time. So please do lots of activities and apply thoroughly so that you get the award.
Thank you, Ashadi, for your kind words and your encouragement always. And I've already communicated to Dr. Brejbala. I think before start of the webinar only, we got the email from the ISAR office about Dr. Rajat Ray Best Committee, Best Chapter Award, and we are working on it. And I think she has already prepared a document. So we'll be soon sending it. And I hope that all our members, those who are working, give their activities and we compile up and send it. So with your blessings, we'll definitely make it to the best chapter this year. So thank you very much for being here and supporting us. And now we go on to the scientific program. I welcome those again who have joined late, and we'll start with our scientific session. Thank you.
Ma'am, we would also like to introduce Dr. Brajbala Tiwari, ma'am, the
Yes,
office
please.
bearer for
Yes,
the
please go ahead.
uh,
Shruti, can we have the CV of Brajbala ma'am, please? Yes.
So, Dr. Brajbala ma'am is the managing director for the Life Care Hospital. She is also the chairperson for Foxy Environmental Health Committee 2025 and 27, secretary for MPSR 2025-27, and secretary ISOPAP chapter Indore 23-25, past president for Indore OBGY. She has to her accolades many, many.
Thank you, Kalyani. I think. Thank you,
She's
Kalyani.
also the
I
recipient
think
in the national and international conferences. And she is one of the person who always encourages the youth like us to come forward and to take ahead with, a lot of activities. And I'm sure under her ages, we are going to do multiple activities as well as under with Dr. Baser and Dr. Bakshi, ma'am. So ma'am, the stage is to you. If you're okay, ma'am, if you can formally introduce the chairpersons for the session today, and then we'll go ahead with the first lecture.
thank you, Kalyani, for the kind introduction. And greetings from MP Chapter ISAR. As Secretary MP Chapter, I welcome all the faculties, guests, chief guests, Dr. Alka Pandey Madam, Dr. Bakshi Madam, all the speakers for agreeing for this MP Chapter ISAR webinar and spending their valuable time. So now we are going to start with our academic session, and for that we are having chairperson Dr. Puneet Arora and Dr. Anjali Kanare, and speaker is Dr. Rakhi Singh. May I have the CV of Dr. Puneet Arora, please? And with the best wishes from Dr. Bakshi Madam, we are going to apply for a Best Chapter Award this year. So, Dr. Puneet Arora Madam is Fertility Preservation Society founder member and treasurer, and she's executive member of Gurgaon OBGY Society, medical advisor, Cancer Survivorship Project, Cankind, and she's associated with many associations and awarded with Bharat Gaurav Award for excellence in field of reproductive medicine 2016, Asia Pacific Medical Excellence Award 2023, Most Trusted Women Healthcare Leadership Award in Gynecology and IVF in 2024, and Most Iconic Gynecologist and IVF in North India 2025, Women's Super Achiever Award OBGY 2025, and so many publications to her credit, around 50 publications in high impact journals, author of numerous chapters in various fertility books. So I welcome you, Dr. Puneet, for this MP Chapter Award to chair the session.
Thank you.
May I have the CV of Dr. Anjali Kumar? Can we have CV of, yeah. So Dr. Anjali Kanare is very good friend of ours, and madam is from Bhopal. She is past president of Bhopal OBGY, professor and head in Department of OBGY, Chirayu Medical College, Bhopal. And she had been awarded with Dr. Jagdeshwari Mishra Best Poster for 3 consecutive years in AICOG, 2014 Patna, 2013 Mumbai, and 2012 Varanasi. And she has special interest in high-risk pregnancy and very active academician. So I welcome you, Dr. Anjali ma'am, for this session chairing.
Thank you,
Over
ma'am.
to you to introduce our speaker.
We need to have Dr. Rakhi also, Dr.
Yes, ma'am. Ma'am, Dr. Rakhi
Rakhi's
Singh is
CV.
also one of the
Dr.
chairpersons.
Yeah. So we are having Dr. Rakhi Singh with us.
Yeah, so please invite Dr.
Is
Rakhi.
well-known figure in Foxy. Dr. Rakhi Singh Madam is president of Noida Society, and she is Governing Council member of ICOG, vice chair of UP State ISAR, and Madam was past chair endocrinology committee Foxy, peer reviewer of journals for OBGY Jogi, and awarded many times, invited faculty for more than 380 conferences, national as well as international, convener for Foxy ICOG GCPR, updates in management of PCOS 2023, editor Foxy Focus, Harmony of Hormones 2023, DC Datta Award Foxy publication in 2022 AICOG. Foxy CS Dawn first prize in 2023, written 46 chapters in various books. So we welcome you, Dr. Rakhi, for this session. Over to you, Dr. Rakhi.
Thank you so much, ma'am, for the kind introduction for our chairpersons. Now, as we move forward, I request Dr. Archana Basir, ma'am, to start her very, very important topic, and that is the progesterone wars, which, when, and how long to prevent recurrent pregnancy losses. So, over to you, ma'am, for your talk.
Shall I get the opportunity to introduce Madam? Though Madam doesn't need any introduction, but she's a very good friend. And the best part is she's a wonderful teacher. I know her for her ultrasound work. And the another thing which I saw today was she has included so many youngsters. It is unbelievable to go through their CVs and their photographs. Kudos, Madam, and all the best for your upcoming elections.
Thank you so much. And yeah, because selecting the all the on this platform. So Rudri,
Ma'am, your voice is breaking.
Yes, ma'am, your voice is not clear, ma'am.
I think some network issue with ma'am.
Yes, ma'am.
hello.
Hello, ma'am. Now we can hear you.
So can I be allowed to share my screen, please?
Yes, ma'am, please.
Hello.
Ma'am, are
we
you
can
able
hear
to
you.
share your screen? Yes, ma'am.
Shruti, is there any issue with our end or ma'am's
No, no, no.
internet?
There is no issue with
I
the
think it is, ma'am.
internet.
Maybe
Sharing rights already given to
Mm.
all, madam.
Okay, so maybe we can just call for her PPT and we can run it from here. If
Sure, we don't have PPT. Should I call her up and ask?
yeah, just call her up and ask, please.
Okay.
Ma'am, Archana ma'am is saying to start with Shivani ma'am's talk, if we could do that.
So is
Shivani
Dr.
ma'am, would you like
Shivani is
to talk to
here?
Shivani?
Shivani ma'am is.
Dr. Shivani ma'am has not joined. I think she was saying that she is going to be in another meeting. Can we have the panel discussion first if it's possible?
Achal ma'am, can we start with the panel discussion if
Shall I
everything
call
goes
Dr.
okay?
Shivani first?
Yes, ma'am. Brajman, you can speak to Shivani ma'am first.
Yeah, I'm calling Shivani.
I think till the time the hiccups are coming, falling into place properly, and we start with our presentation, one thing which I would like to mention is, which was rightly said by Archana Madam and our both the teachers, Alka madam and Asha madam, that RPL is one of the cause for patients coming for infertility treatment now. If they are not counseled well after their losses, then they delay pregnancy. There is a lot of psycho social element which plays into their life. They are scared of conception again. They are scared of having medicines again. And then they start falling into the criteria where they have to see a IVF specialist for their treatment. So today's topic is rightly being placed on this platform, which covers infertility as well as RPL, because what we see even in our medical college, where we have IVF setup, at least out of 10, every month, one or two patients are coming with recurrent pregnancy loss for treatment for infertility. So, gone are those days when there used to be only obstetric cause for reproductive pregnancy loss. Now, there are so many factors: weight, age, um, their work issues. All these factors are coming into picture, and we need to be really aware about how to treat such patients for RPL as well as infertility treatment, how to counsel them, how to call them up for recurrent investigations. And I'm sure, as Madam has rightly put up in the start, what treatment to give and how to give, because as we all are aware, Brijbala Madam, let me know whenever you are ready. I can.
I'm ready. I think
Yeah.
I had some
Madam is ready, I think.
connection, so I
Okay,
moved
that's
to
great.
another place.
So,
So
yeah,
please.
so we can start now. Definitely, we can start with Archana Madam's talk.
So is it okay now? Am I
Yes,
being
we can see. Yes, we can see you,
you
Madam.
can
Very
hear
much.
me better? Yeah.
Yeah, yeah.
So again, a very good evening to all of you. I think the topic which my conveners have chosen for me is progesterone wars. Which, when, and how long? I think it's a very interesting topic because we all are, practicing for more than like 2, 3 decades, and some youngsters are here today. I think progesterone has been there since long in use in OBGYN, but still there are challenges we face, that which one to use and how long to use and which one is better, because there will be always some or other controversy, or we are waiting for some evidences. So what I'm going to do, like, this is what I say: progesterone is a hero to maintain the pregnancy, let it be recurrent pregnancy loss or let it be implantation failure. So in infertility or in maintaining the pregnancy, having the pregnancy, maintaining the pregnancy, both ways progesterone is needed. So I will be talking when to start progesterone, which progesterone to be used, and how long to continue progesterone, and how to make a perfect blend in the cocktail of progesterone. So let me begin with, like luteal phase defect. As we say that as recurrent pregnancy loss, it doesn't begin after the conception, it begins with before the conception, when there is like a deficiency of the progesterone, or the corpus luteum is deficient. So I'm just covering that a little bit. Inadequate secretory transformation of endometrium resulting from deficient progesterone production, and it is implicated both in infertility and in recurrent pregnancy loss. And prevalence of luteal phase defect is 3 to 20% of patients who are infertile, and 5 to 60% of patients experiencing recurrent pregnancy loss. What happens? There is a poor follicle growth, FSH or ovaries not responding to FSH, inadequate follicle development, poor quality, malfunctioning of the corpus luteum, containing less number of luteal cells, low progesterone, early menses. Defective corpus luteum, different origins of defective corpus luteum. Either there can be a poor follicle leading to poor corpus luteum. During ART, follicular picture can be one origin, follicle puncture can be one origin, and decreased LH or fewer LH receptors or ovary not responding to LH. There can be premature failure of corpus luteum. There can be a failure of uterine lining to respond. So for reasons not fully understood, the corpus luteum does not persist as long as it should, and low progesterone, and again early menses. And that's why the women who keeps coming with recurrent implant, like infertility or recurrent pregnancy loss, they invariably say that cycles are short. So the uterine lining, failure of uterine lining to respond, this is very important. The uterine lining does not respond to normal levels of progesterone, maybe due to endometrial nuclear progesterone receptors less, and the implantation of embryo will fail. So these are the problems associated. Now, why does a luteal phase defect occur in natural cycle? We know that in the ART cycles it is expected, but why in natural cycle also we do get LPD? There is hypothalamo pituitary and ovarian excess. We know that. So there is abnormal FSH-LH leads to faulty estrogen progesterone receptor and endometrium not prepared properly. So that all is responsible for an inappropriate luteal phase in natural cycles, and that leads to defective folliculogenesis, poor endometrial preparation, and leads to infertility and recurrent abortions. So luteal phase, we know that we are using oral ovulogens. So in the oral ovulation induction also, the luteal phase becomes sometimes defective, because clomiphene, when we were used to use clomiphene a lot, still it is being used into luteal phase. There is anti-estrogenic effect, and abnormal LH persists. Frequency with both endometrial receptivity is affected. And clomiphene and letrozole cycles result in less receptive endometrium. That leads to, again, that may be one of the reason for problem in conceiving and pregnancy loss. So luteal phase and gonadotrophin stimulation, there is a supraphysiological level of estrogen progesterone, incomplete luteinization, and the luteal phase in gonadotrophin cycle is inadequate and varies with the degree of stimulation. Now, luteal phase in ART cycles, there is effect of gonadotrophins, GnRH agonist and antagonist. They block tonic LH secretion. Luteolysis occurs when agonist is stopped. So all ART cycles require luteal phase support. So the progesterone is very, very important in ART and even in non-ART when the patients are coming for the fertility treatment and in early pregnancy support in the women who are having recurrent pregnancy loss. So what are the rationale for luteal phase support in ART? In ART, low progesterone environment is created iatrogenically due to intervention. And GnRH analog, both agonist and antagonist, they suppresses gonadotrophin secretion. Once down-regulated, pituitary function does not resume until 2 to 3 weeks after the end of GnRH therapy. And as corpus luteum function is dependent on pituitary LH stimulation, luteus phase support is considered prudent to prevent any progesterone deficiency that might jeopardize success of implantation or early pregnancy. So rationale for luteal phase support again in ART, because of HCG administered for final oocyte administration suppresses LH production via short loop feedback. Supraphysiological levels of steroids secreted by high number of corpora lutea during early luteal phase directly inhibits LH release via negative feedback, and luteal phase LH levels found to be low in HMG only cycles. Defective LH secretion might induce a luteal phase defect in stimulated cycle. So this is again the rationale for luteal phase support in pregnancy, because progesterone secretion by the corpus luteum is for the success of early human pregnancy. That is the key word. And it supports endometrial growth. It improves blood flow and oxygen supply by increased nitric oxide production. It keeps myometrium quiescent by uterus relaxing effect, and it sustains survival of embryo by shifting immune system towards production of T helper Th2 response. Now, how do you manage like luteal phase defect? By progesterone plus estrogen, and HCG in the luteal phase. Now, we have different sorts of progesterones available in the market, and all of us are using different preparation in the different doses. So we have natural micronized progesterone, which can be administered via different routes. Natural micronized progesterone formulations, we have oral routes, capsules, sustained release tablets. We have gels, capsules, effervescent tablet. We have intramuscular oil-based injection, intramuscular aqua-based injection, and subcutaneous aqua-based injection. And there can be rectal capsules. And we have oral progesterogens as well, like dydrogesterone. So clinical evidence, which route is better? Now the question comes, you have different things available. Can you use all the routes for everyone, or you have to be route specific? So I think what they have done, there are lots of studies about the progesterone. I think largest number of studies, if you go through the literature, are about the progesterone, role of progesterone, how the progesterone should be given, and what dose of progesterone should be given. So among different routes of administration, there are no statistically significant difference between intramuscular progesterone and other routes like vaginal, oral, rectal for IVF cycle, or fresh and frozen embryo transfer cycle. And there is no statistically significant difference in live birth rate between intramuscular versus oral and versus vaginal and rectal route. So this is very important. Like, whatever is your practice, so you can, and if you are finding the good results with that, you just have to see evidences, and then you may continue with the whatever you have been using. So progesterone has different pharmacokinetics and pharmacodynamics properties when used in different routes of administration. So the progesterone supplementation route, vaginal route, progesterone gel, progesterone effervescent tablet, and progesterone capsules. The only the advantage of vaginal route is higher uterine progesterone concentration with low peripheral serum values. So uterine first pass effect, where liver metabolization is absent, and counter current exchange in progesterone transport between anatomically closed blood vessels. So this is how the first pass effect of progesterone when used by the vaginal route. So this is counter current transfer of progesterone from vaginal veins to uterine arteries, transferred to cervix, intracervical aspiration, different diffusion of progesterone from vagina to uterus, transport of progesterone from lymphatic and venous circulatory system. So that's why, but only thing, women might find it cumbersome or not very happy when they are pregnant using the vaginal progesterone. So this is an updated systematic review meta-analysis where they evaluated patients undergoing ovulation induction and IUI for infertility, 11 randomized controlled trials with in exogenous progesterone luteal phase support was given, and the main outcome measure was live birth. And what they found in that luteal phase progesterone supplementation in cycles which are oral ovulogens were given can improve endometrial receptivity is judged by improved clinical pregnancy rate. So ultimately, everything boils down to the clinical pregnancy rate, and they have found that luteal-based support, whether it's with the oral ovulogens or in the IUI, that is very good, and it gives a good live birth rate. So even abnormal luteal function is common even in IUI. So luteal support with progesterone during IUI cycle improves pregnancy outcome. Now, these are the different trials where the meta-analysis was done, and this is the Cochrane database reviews where they have compared different routes, and what they have found that there is no difference. Now, micronized vaginal progesterone versus progesterone gel for LPS, 5 randomized control trial, no difference in implantation rate or clinical pregnancy rate was found. So, I mean, again, studies where progesterone routes and types were compared. So, vaginal is effective as intramuscular or oral. So, it obviates the, intramuscular injections. If you use vaginal, it is, I mean, patient doesn't have to come to the hospital for giving the intramuscular injection. And vaginal route is safer and more patient friendly than intramuscular or oral, because a lot of somnolence is being reported after the oral injection of the progesterone, and so it is much safer and better. Now you can use a GnRH agonist also for luteal support. I'm not going to get into that detail. And then again a Cochrane review where they had 94 women randomized control trial. They included 26,198, when what they found, higher rate of live births on ongoing pregnancy in progesterone group. Now progesterone during luteal phase is associated with higher rates of live birth or ongoing pregnancy than placebo. Now, the very important question is when to start luteal phase support. Like some start on the day of the HCG, some would start in IVF on oocyte retrieval, some would start on day of the embryo transfer. So prospective randomized trial in oocyte donation program, they found no difference in implantation, pregnancy, and ongoing pregnancies when progesterone was delayed until the day of fertilization. So I think again, it is, it is very, very, your experience based how and when do you start progesterone? Like in our practice, we start progesterone on the day of the month of the IVF cycle. And in oral ovulation, when we are giving, we are supporting them with the progesterone, and we start on day 16 or day 18 of the cycle, that is 2 or 3 days post ovulation, confirmed ovulation. Now, the next very important question is how long to give luteal phase support. Like different people, again, the different policies. So usually given till 8 weeks when the placenta takes over the function of producing hormone. Some would use up to 12 weeks. But if you go through the guidelines, what ASRM guidelines say, there is no proven role in
Basir ma'am, your voice has been muted.
again, there is a problem.
Yeah,
No?
yeah. No, ma'am, we can hear you now.
So, time of expected menses, that is 2 weeks after ovulation, is not proven beneficial. But if I'll ask the question to our members here, I think everybody will have different experience. Some would use till nuchal scan, some are going to use it till anomaly scan, some will use till 28 weeks. I think it depends on your past experiences. You will be using it, but in the nutshell, overall, you use it up to the 8 weeks in ART cycles. And if the patient had recurrent pregnancy loss, I think the loss which she had previous loss, you will go beyond that and then continue the progesterone till then. Now, what is the optimal dose of progesterone? There is no current consensus on minimal mid-luteal progesterone levels required for adequate luteal phase in stimulated cycle. So optimal dose for progesterone is not identified. Dose based on route of administration. So if you are using vaginal route, in IVF cycles, you use 200 milligram 3 times a day, intramuscular 50 milligram to 100 milligram once a day, based on the weight of the patient. And if you are using vaginal or intramuscular administration, which provides optimal endometrial receptivity, and oral route is not recommended because greater chance of out of phase endometrium. So it is important which route you are using. So with this, progesterone is an important, very, very important hormone to be used in infertility and recurrent pregnancy loss. So just the message I want to leave with is in ovarian stimulation cycles, luteal endocrinology and endometrium is complicated by possible effect of pituitary downregulation with GnRH analogs and use of HCG and GnRH to trigger oocyte maturation. Endometrium is subject to altered endocrinological environment due to supraphysiological steroid levels, which are responsible for impaired implantation. So luteal phase support is essential in all ART cycles and those non-ART ovulation induction cycle which use gonadotropin and GnRH analogs. It is a very important hormone, and the dose has to be really optimum dose has to be used, and optimum time has to be used for the progesterone. Because suppose if you are using progesterone for a shorter time and your patient had again a pregnancy loss, then there will be question, why did you not continue it? So I think you have to decide depending on your experience how long you're going to use the progesterone, but it is very, very important hormone. And thank you very much for the patient listening, and sorry for in between the technical problems. And I appeal everyone to support me for my presidential candidature in election year 2026 for Foxy. Thank you very much.
May I request a chairperson for their remarks? Dr. Raki or Dr. Puneet or Dr. Anjali ma'am?
Yeah, thank you. Thank you so much, Dr. Archana ma'am. So it was very enlightening talk. I think this has always been a controversial topic. Some of the aspects, we know that this is the most important hormone, one of the most important hormones, and controversial to start, when to finish, what is the route, so I think you have very clearly given a very evidence-based approach to all these questions. So thank you so much for this enlightening lecture. Thank you.
Thank you, Dr. Anjali, for staying with us and patient listening.
It was a lucid presentation, madam, as usual.
Thank you.
Can we proceed for the next talk?
Yes, ma'am.
Dr.
Yes,
Rudri,
ma'am. Yes,
please
ma'am.
invite Dr.
Thank you
Shivani.
so much, Archana ma'am, and our chairpersons to conclude. And this was a very, very informative talk for each and everyone. Now, can I go with the second lecture? And for the second lecture, we have very eminent and esteemed faculty with us, Dr. Shivani Sachdev Gaur, madam. And may I request Dr. Brajbala ma'am to introduce our next speaker, Dr. Shivani ma'am, for all of us.
Thank you, Rudri. And we are having very, very good friend, beautiful with beautiful brain and beautiful from inside out, Dr. Shivani Sasdeva. And she's director as SCI IVF Hospital, Clinical Research Fellow from Imperial College, and featured in Limca Book of Records, Founder Secretary of Delhi State Chapter of ISAR, General Secretary Star, General Secretary Delhi State Chapter of ISPAT, ex-Vice President Delhi Gynae Forum South, and Vice Chair of Women Dr. Wing, IMA South Delhi. And she is well-known figure in ISAR and Foxy. So I invite Dr. Shivani.
Thank you very much, dear Dr. Brijbala. And I am so honored to visit your place, wonderful, magnificent palace, not once but just 2 times. And Dr. Archana Baser, ma'am, my very, very heartfelt best wishes are with you for great success. And thank you, our esteemed chief guest, Dr. Alka, ma'am. मतलब इतना honor है कि आप मैम हो, आपको प्रणाम दिल्ली से. And Dr. Asha Bakshi, I was with Dr. Asha Bakshi in the previous webinar from where I have just joined here. And Dr. Rakhi Singh, incidentally, I was just at Noida Society. She is in Chandigarh. So giving a talk there. Dr. Kalyani, very dear friend of mine. Dr. Puneet from here, very dear Dr. Rudri and Dr. Anjali. Thank you all the delegates also who are here for this wonderful program, and my best wishes to the upcoming moderator, my dear friend Dr. Anchal and Dr. Ruchi Agarwal for your upcoming session. So I will be sharing my screen now about the RPL. So can you see the screen?
Yeah.
Yes. Okay. So, RPL, thank you, Archana ma'am, giving me such a wonderful topic. Do less, do right. So, let us start by discussing how do we classify RPL? Is it after 2 losses, 3? So, start following after 2 consecutive losses. And in case if you have a mid-trimester loss, then your, sorry, I think I went a little. Yeah. So in case there is a mid-trimester loss, then the evaluation should start immediately after the first loss, and it should be tailored according to the woman and her partner's age, the history, the emotional state, availability of test, and finances. Now, why does this happen, RPL? unknown etiology almost 50% of the cases, which is the most frustrating part of this. The other causes could be genetic, infectious, endocrine, environmental, immunological, psychological, anatomical. We are from Delhi here. AQI, you will not believe, in the morning you check the phone, it is 500, 700. Unheard of AQI is going on here. And what I read was a paper from China saying that just pollution itself can be responsible for up to 7% of pregnancy losses. So definitely now environmental factors have become very common. But we must also remember, I mean, I really love this slide, that there is 60-70% chance of successful pregnancy if there is no cause found for recurrent miscarriage. So now, what are the various points a couple comes to me in the clinic? What will be the points that I need to elicit on history? First of all, I need to know if it is a spontaneous abortion, was it chemical pregnancy, or was it after heartbeat or before heartbeat? Was it second trimester or stillbirth, full term or premature? Was the baby malformed? What was the term of pregnancy? And after that, I will go into her lifestyle factors, like is she obese? What is the daily caffeine intake more than 300 milligram? Is there alcohol consumption, NSAIDs, environmental factors like smoking, anesthetic gases, toxins, chemicals? So these are all the points that I would focus on in the history. Then what about investigations? The tests that we recommend, GTT, very important. In our Indian population, even young girls will come out as pre-diabetic. So HbA1c is not enough. A glucose tolerance test, thyroid, if more than 2.5, then antibodies, antiphospholipid antibodies, anticardiolipin, beta 2 microglobulin, and prolactin. If you see an ovulatory dysfunction, testing for inherited thrombophilia is not recommended unless we have a history of thrombosis in the family. Of course, a TVS, and it is said that a sonohystrography is supposed to be better than an HSG test. And I'm sure now we all are aware of these newer tests for chronic endometritis. Selected patient, not for all, but 17 alpha hydroxyprogesterone or serum progesterone, corpus luteum vascularity, TB PCR culture, homocysteine, thrombophilia, HVS, and semen culture, and even semen. If you find some infection, then TB PCR in the semen. So now coming to what can we do for our uterine factors of RPL. It can be an acquired anomaly or a congenital anomaly, of which congenital is about 10 to 15% of the cases, in which the main problem is with implantation, where there can be reduced vascularity, increased inflammation, and reduced sensitivity to steroid hormones. The number one cause for anatomically that we see is septate uterus. And the best part of septate uterus is that once you treat it, the pregnancy rates are excellent. Septate uterus is most common seen. There is no doubt in literature that it is associated with poor outcome. There is no question about it. Miscarriage rate more than 60%, fetal survival with untreated cases only 6 to 28%. The exact mechanism is not clearly understood, but it is believed to be poor blood supply, poor implantation. Submucous leiomyoma, their position by their poor endometrial receptivity around it and degeneration, increased cytokine production can be a cause. Other causes are like polyp, adhesion, curettage previously, if it has been done, which has traumatized the basalis layer, and there is insufficient endometrium to support the placental tissue, which can be recognized by menstrual irregularities like hypomenorrhea, amenorrhea, cyclic pain, or infertility. There can also be factors like cervical insufficiency, where you have recurrent mid-trimester loss or other anomalies, or rare cases of DES exposure. So what is the most common assessment we use? We have sonohystrography or HSG or a hysteroscopy. Hysteroscopy is, of course, the gold standard for diagnosis. And if you have done everything and you have not got any result, it is very important to do a diagnostic hysteroscopy. And what I tell my patients is that when I do a hysteroscopy, I see, is the cavity pink or is it red? Is it yellowish? Sometimes it is little brownish. You see spots of adenomyosis. So hysteroscopy is gold standard we can evaluate if your uterus is ready to carry the pregnancy or not. Ultrasound can be helpful for presence and location of uterine myomas. In MRI, you can differentiate septate from biconvate uterus. So, hysteroscopy, laparoscopy, MRI, of course, are second line tests when other tests have come normal, and the treatment is by surgery, septum excision, or polypectomy, or myomectomy. Now, how can you suspect and diagnose cervical incompetence? The diagnosis is a typical history you will get of rupture of membranes and quick delivery. In the non-pregnant state, it is said that if you can pass number 8 Hagar's dilator without resistance, or an HSG will show funneling in the internal os, that indicates insufficiency. Women with second trimester miscarriage cervical weakness may be offered serial cervical sonographic surveillance, and who have one second trimester miscarriage, ultrasound in means which is attributable to cervical factors, then definitely cerclage should be recommended. What is the role of immunological mechanisms? And immunological factors we can classify into autoimmune like SLE or antiphospholipid, and alloimmune, that is an abnormal maternal response to the foreign antigen, which is the fetus or placental antigen. And these are the two most famous cells really, and we should remember. So there is the NK cell, which is the CD56 bright and CD56 dim. The difference between them is the dim one is in the peripheral blood and it has low cytokine production. The bright one is the uterine. So this is why it is said that when you do a blood test for NK cell, you may not pick up the correct NK cell because the uterine NK cell is CD56 bright and that has high cytokine production. Now, coming to the autoimmune factors with SLE, the risk of loss is almost 20%, mostly second and third trimester. In antiphospholipid antibody syndrome, 5 to 15% of your patients who come with a recurrent pregnancy loss could have it, and it induces microthrombi at the site of placentation with altered vascularity. So, we all know there is a Sapporo criteria with at least one of each: thrombotic events, pregnancy loss more than 3 at less than 10 weeks gestation, or fetal death after 10 weeks, premature birth less than 34 weeks with severe placental insufficiency. Laboratory technique is LAC, ACL, IgG, IgM at least 2 times 6 weeks apart. What is the treatment? Antiphospholipid antibody. Lower molecular weight heparin 3000 IU subcut twice a day. It is expensive. Unfractionated heparin may be a better option. Low dose aspirin. Steroids mainly if you get anti-nuclear antibody positive, then aspirin and steroid both. Which steroid you use? Prednisolone, that is 10 to 20 milligram per day. Now, coming to all alloimmune mechanism, this is becoming very important now because we see many patients now they are coming with antibodies related problem in pregnancy losses. Normally, the pregnancy is tolerated by the immune system, but if there is an abnormal immune response, then we can get recurrent pregnancy loss. Although previous studies have concluded that there is a higher degree of HLA sharing, multiple investigators have attempted to modulate the immune response using paternal white blood cell immunization, IV immunoglobulin, donor seminal plasma, but none have been shown to be useful. The treatment that is most commonly done is that the husband's lymphocyte suspension, 300 ml of blood means 10 ml suspension, 5 ml is given IV, 1 subcut and 1 intradermal, and these are the LIT or the immunosuppressive therapies where it stimulates the maternal immune system, and there is a lot of reports to suggest that this may benefit patient, but there is no credible or honest clinical laboratory technique that you can identify which patient will benefit from such therapy. And always remember there is a risk to the mother, maybe a risk of IUGR or other complications. Then this is again about immunology. What about HLA testing? Some people are doing blood tests for HLA. Now that is not recommended in clinical practice. Only HLA class 2 determination could be given some credibility in Scandinavian women, and that also look at the rare criteria. They've said secondary RPL after the birth of boy for prognostic reasons. So HLA is in an area which is a gray area. We don't really know. What about anti-nuclear antibodies? Now, personally, let me tell you, I am doing anti-nuclear antibodies for all my patients, especially if they have two IVF failed, because there is a role of immune factors, and we cannot do the whole panoply of tests, but ANA is the single most important test. There is not sufficient evidence to recommend NK cells, whether it is peripheral blood or endometrial tissue, and HLA antibodies also is not recommended. ANA can be done as an explanation purpose. There is no treatment, but you can give a combination of aspirin and steroid like prednisolone. Now for thrombophilia, we have low risk thrombophilia like factor V Leiden or protein C, protein S deficiency, which are managed with antepartum surveillance or a prophylactic low molecular weight heparin or unfractionated heparin. Postpartum anticoagulation is needed where there is risk factors like obesity, prolonged immobilization, and venous thromboembolism history. Whereas if you have the higher risk thrombophilia like antithrombin or prothrombin 3 mutation, factor V Leiden, then in these cases, we have to give prophylactic antepartum anticoagulation along with postcoagulation therapy. Acquired thrombophilia, antiphospholipid antibodies being the most common, and treatment is combined low dose aspirin with low molecular weight heparin or unfractionated heparin, which has been proven effective. Now, what is the value of thrombophilia screening? We suggest not to screen for hereditary thrombophilia unless there are additional risk factors. You can screen for antiphospholipids. So you can do lupus anticoagulant, anticardiolipin after 2 losses, and beta-2 glycoprotein 1 antibodies also can be considered. For women who have history of RPL, we suggest not to use antithrombotic prophylaxis unless there is indication to prevent thromboembolism. And in women who have 3 or more losses, you can use aspirin 75 to 100 milligrams a day, started before pregnancy. This is important. So tell the patient when she's trying for pregnancy, she can start it at that time itself. And when the pregnancy test is positive, you can add low molecular weight heparin. Coming to some endocrine factors, itself PCOS, biggest factor for RPL, where there is high LH level, may be associated with diabetes, hypothyroidism, and luteal phase insufficiency. So screening of TSH anti-TPO antibodies is generally done when the TSH is more than 2.5. And if you have antibodies positive, then it can affect the pregnancy outcome. So in these kind of cases, it is suggested that if the TSH is increased, it could, and free T3, free T4 are normal, it could be subclinical hypothyroidism, but still you can do the treatment. So even if your free T3, T4 is normal, you can start Thyronorm 25 microgram every 2 to 4 weeks till the euthyroid state is achieved, or just maintain it throughout the pregnancy till at least 7 to 9 weeks of pregnancy. What is the value of screening for endocrine or metabolic abnormalities like these thyroid peroxidase antibodies? It is definitely recommended. Abnormal TSH, TPO antibody should be followed by a free T4 testing. We should also screen for PCOS, fasting insulin, and glucose, although the insulin and glucose are not recommended routinely. Prolactin testing, if clinically there is no hyperprolactinemia, it is not recommended. Ovarian reserve is also not routinely recommended for RPL. Androgen testing not recommended. LH not routinely recommended. Luteal phase insufficiently not routinely recommended. Now, a very big factor, that is infections. There is no causal role of infections in RPL. Microorganisms which can be found sporadically are mycoplasma, ureaplasma, chlamydia, bacterial vaginosis. Routine torch testing is definitely not recommended, and tuberculosis 100% can be a factor for recurrent miscarriage, and there is no proper diagnosis for this, as we all know. So it's up to you whether you just do a Mantoux test or you do a laparoscopy and you see tubercles, or you do a TB PCR. cure starts with the detection. What about genetic evaluation? When should you do genetic? It is said that the POC of the second abortus, and especially by SNP, single nucleotide or CGH, is recommended. It is definitely better than karyotyping. Parental karyotyping is ordered if there is chromosomal abnormality, and in the absence of POC karyotype or euplite, full maternal workup of RPL. Paternal karyotyping not routinely recommended unless there is a strong history of RPL. So these are, of course, all the problems because of which NGS and CGH are recommended. And this is just a summary of what I've just said. So genetic testing is not routinely recommended, but if you have more than 2 losses, then especially the second loss is recommended by array CGH or NGS. Now, what about lifestyle modification? The first thing and the easiest thing we can tell patients is cigarette smoking, relative risk 1.3, alcohol 2 times, obesity more than 30, independent risk factor for RPL, caffeine intake 100 milligram if you presume in 1 cup. So 300, more than 300, that is 3 cups or more per day is associated with miscarriage. Not only that, psychological factors, environmental factors. For the males, sperm DNA fragmentation can be done. What does the quality of the male gametes contribute? Yes, definitely. 50% is up to the male. So assessing DNA fragmentation can be considered based on indirect evidence. Lifestyle factors are recommended. Therapeutic options, of course, we should tell them that smoking, alcohol, obesity, and too extreme exercise, that is the size, zero figure, and all, can be a negative impact. And antioxidants have not shown to improve the, I mean, it is controversial whether it may be improved or not. For unexplained, apart from tender loving care, what can you do? 50% are unknown causes. It could be the egg, reduce oocyte quality, sperm factor, endometrium factor, immunological factor. So this is where perhaps you can suggest PGT testing, where you can do a genetic testing, and if nothing else works, then last option we go for donor gametes. So unexplained, most important, psychological support. Aspirin 75 milligram once a day, progesterone, low molecular weight heparin, HCG, steroid, immunoglobulin, intralipid, all these are the suggested options, but as you can see, there is no good evidence for anyone. Ovarian stimulation, yes. If the pregnancy is conceived by IVF, how the ovarian stimulation has been done, that can also have an effect on the RPL. But especially in patients with PCOS. Luteal phase deficiency, of course, if progesterone is essential for implantation and if there is a defect, but the main problem for LPD is how to diagnose it, because there are no consistent factors or tests to diagnose. Yet progesterone has come up very strongly in RPL, like the PROMISE trial. What was shown was that there is a link between immunological system and the immune system, and if you use progesterone in terms of RCTs, there is no robust evidence that women who have recurrent pregnancy losses, by giving progesterone, you can prevent miscarriage. However, there is some evidence that women who have suffered 3 or more miscarriage may benefit from progesterone during pregnancy. So again, there is a big debate. There is nothing which is definitely proven. Literature does not allow any specific treatment for idiopathic pregnancy loss, with the exception of progesterone starting from ovulation. So this is from Acta Obstetrica. So there is a lot of debate in the literature about progesterone. Progesterone not only has a supportive effect, but immunomodulatory shift, because it shifts from Th1 cytokine to Ch2 cytokine, and especially dydrogesterone produces PIBF, which is a protein produced by the pregnancy lymphocyte, and that has an effect on cytotoxicity and NK cell activity. So definitely in patients with 3 miscarriages miscarriage, no question, we can give progesterone. It is supported by the literature. You can give oral or vaginal based on your own evaluation. And this was the promised trial, that there is no evidence that the first trimester progesterone therapy improves the outcome in women who have history of unexplained recurrent miscarriages. Now, what are the international guidelines? Some of them for women who present with clinical diagnosis of threatened miscarriage, there is reduction in spontaneous miscarriage with progesterone. 2015 progesterone also is supported. What is the Foxy position statement? That is, there is no evidence of harm, some evidence of benefit. So it is based on your discretion. Then this is a brief summary about RPL, more than 2 pregnancy losses, the not recommended test, recommended. So there is a lot of debate on what tests can be done, but what they are suggesting is tender loving care, vitamin D, and lifestyle advice is probably the best. And these are some of the supplements which have been used. Vitamin D, now again, I found some other studies which say that there is no association. Some studies say vitamin D itself and iron deficiency can be associated with RPL. So I am supplementing all my patients with vitamin D and iron, especially if I am suspecting that there could be a case of RPL. So basically, we come down to the workup of RPL with recommended test is uterine evaluation, thrombophilia, thyroid, and diabetes. Tests for explanation like genetic tests, immunological, sperm DNA, hereditary, and tests which are not recommended. In general, it is said that some immunological test or cytokine test or insulin, glucose may or may not be recommended. So this was again about PGT. In summary, I would like to say that recurrent pregnancy loss is devastating. It is major loss, affects 1% of women. Spontaneous miscarriage occurs in 12 to 15% of pregnancies. 30% are lost between implantation and 6 weeks. It's a maternal age and previous miscarriage which increases the risk, and management is an unsolved problem. Up to 50% will have no defined etiology, and the investigation and management is one of the most debatable topics, and it is a very significant life event. And don't forget that it is a male partner also who suffers. So it is our job to provide as much support that we can and counseling that we can. And definitely we can say we need much more research towards this topic. So thank you everybody for a very patient hearing.
Very lucid presentation. It was really engaging and informative, Shivani. It was excellent talk.
Thank you, ma'am.
Thank you, Shivani. May I request our chairperson, Dr. Puneet ma'am or Dr. Anjali is there, or Dr. Rakhi?
I think
Yes.
Dr. Rakhi. Hi,
Yeah.
Puneet.
Thank
Good
you.
to see
Hi,
you.
Dr. Shivani. How are you?
Good, good.
Such a beautiful talk. You summarize such a complicated topic in such a nice way that, it was crisp, and very rightly gave important points on what to do and what not to do. Because I think, like you rightly said, it becomes like an emotional journey of us doctors as well with the patients. And sometimes we tend to over investigate and overdo, which ideally we should not do as well because they're already suffering. So I think very nicely done, as expected from you always. So thank you so much for that. Thank you.
Are there any questions, or you can go ahead? So thank you, Shivani, for such very clear guidelines.
Thank you.
Hi, Dr. Puneet.
Thank you, Shivani, for taking out time for MP chapter research. It's always pleasure to listen you.
Thank you. Thank you.
Ma'am, even I would like to add in 2 words. Sorry, my video is not working. So, Dr. Shivani Kalyani here. So, I have known Shivani since I think when I started my career in fertility, since I was in Bombay. So, it's been a long journey that, we have shared together and we have been together and we have been occasionally been together during the conferences, but always so much of pleasure and such a beautiful talk that you presented. Thank you, Shivani ma'am, for the wonderful talk. And I would also like to, introduce Dr. Puneet ma'am. So Puneet ma'am had been, when I started my career with Nova, Puneet ma'am was with me out there. And she always kept on supporting me for every step because I was just, beginning with my tiny steps over there. And she is one of the reasons when I started focusing on fertility preservation when no one was doing it. And I still remember the discussions what I had with Puneet Di for, for the cancer patients. And she used to visit Aurobindo out here to, go ahead, and she was in the committee for the Ferti Protect and to go ahead. So I have learned so much for the protocols in terms of fertility preservations. And I would really like to, Puneet Di, to have you one more time just to speak on the fertility preservations on the cancers. And that was something which I can never forget, which gives me the confidence. And I'm sure you must have given confidence to so many other colleagues of yours to go ahead and to freeze those oocytes, or to go ahead and freeze those oocyte preservation in terms of the fertility preservation. So yes, this webinar organized the program director Baser ma'am has made us connect with each other so well, to with the people, I think, जिनके साथ हम इतने सालों से मिले भी नहीं हैं, और we have not been able to connect with each other, and she has made it a point that we all come together under the banner of MP sir. And I'm sure we are all going to vote for Baser ma'am, because imagine when she is there, we are going to reunite and do wonders together. Thank you, Baser ma'am. Thank you, Braj ma'am, for letting us coordinate this program for you all.
Thank you, Kalyani.
Thank you, Kalyani.
Thank you, Kalyani ma'am. Very well said. And it was really truth that due to Basir ma'am only we are all here together. So heartfelt thanks to Basir ma'am especially, and all the faculties who have joined. So with this positive vibe, we are going to start with the brainstorming panel discussion today. And that is again the case series of RPL, which would be moderated by Dr. Anshul Garg with the esteemed team of panelists with us. So can we have the CV of Dr. Anshul Garg, ma'am? Okay, so Dr. Achal, ma'am, is the Director, Chief Fertility and IVF Consultant in Lucknow. And to her credit, there are multiple awards like ISAR Young Talent Award of 2022, first prize in poster presentation, National ISAR Conference 2025, and multiple awards to her credit are there. We welcome you, ma'am, as one of the esteemed moderator of the panel. Thank you so much for joining. Can we have the CVs of panelists, please? Yeah, so we welcome Dr. Dharna Desai as our esteemed panelist. Ma'am is consultant in Nova IVF Fertility, Vesu, Surat, and she has clinical experience of more than 7 years. We welcome you, Dr. Dharna Desai. Next CV, please. Then Dr. Sharayu Mohite. Dr. Sharayu Mohite is practicing OBGY endoscopic surgeon and a fertility specialist at Pune, Jahangir Hospital. We welcome you, Dr. Sharayu. Thank you for joining us. Then Dr. Richa Ainani, she is consultant and center head at Nova IVF Jaipur, and she has been a great academician. She has been a recipient of gold medals, and she has received multiple awards like ISAR Youth Icon Award in 2023. She has been a joint secretary of JOGS 2025 to 27, and to her credit, there are multiple awards. We welcome you, Dr. Richa. Next, we have Dr. Rushabh Agrawal from Ahmedabad joining us as the next panelist. Dr. Rushabh is Director Consultant at Resham Bhai Hospital and in Ahmedabad, and he is specially skilled in minimal invasive surgery and specialized in high risk obstetrics gynecology, and he is an active member of multiple fertility prestigious societies. We welcome you, Dr. Rishabh. Then we have Dr. Indraneel Jadhav as one of the next panelists. Sir is a senior ART consultant at Nova IVF Fertility in Kolhapur, and he has special interest in minimal access surgery, and he has also done fellowship in fetal medicine. So we welcome you, Dr. Indraneel. Can we have? Yeah. So next we have Dr. Pavitra Sham Sundar as our panelist. Dr. Pavitra is practicing in Hubli and she is consultant at Nova IVF. She has experience of more than 5 to 7 years and she has been recipient of multiple awards and multiple fellowships. So we welcome you, Dr. Pavitra. Next, we have Dr. Kritika Devi as our esteemed panelist. Dr. Kritika is also a senior consultant of Nova IVF Fertility in MRC Nagar, Chennai. She is also holding the post of senior clinical director, and she has over 18 years of experience in reproductive medicine. And she was holding the post of president, International Fertility Research Foundation, and she has presented multiple papers in various prestigious conferences. So we welcome you, ma'am, as a panelist. Next, we have Dr. Aswati Nair, madam, as our panelist. Ma'am is clinical director and a senior consultant at Nova IVF Fertility, Rajouri Garden, New Delhi, and she has successfully treated thousands of infertility patients. She loves to write poetry and stories, and to her credit, there are multiple awards and multiple publications. We welcome you, ma'am. Next, we have Dr. Mahima as our next panelist. Ma'am is Director of Active Fertility and Gynae Clinic, and she is presently consultant at Fortis La Famille, New Delhi, visiting consultant at Nova IVF Vasant Vihar, and also at Bloom IVF. She has been a recipient of various prestigious awards like Dr. Subhash Mukhopadhyay Award, ISAR Young Achiever Award, and multiple awards. So we welcome you, Dr. Mahima. Also, we would like to extend a warm welcome to Dr. Parth Joshi, who is consultant and chief IVF expert at Indira Hospital, Ahmedabad. And especially mentioning Dr. Parth is very kind that almost he always accepts our invitation to join as the esteemed panelist. And he has attended many conferences and many awards are there to his credit. So we welcome you, Dr. Parth, as one of the esteemed panelists. Thank you so much. Now, can I request Dr. Achal Garg to continue with the panel discussion?
Thank you so much, dear Dr. Rudri. A very good
Thank-
evening to all the distinguished faculty and my respected seniors, dear colleagues. At the outset, I want to express my gratitude to respected Dr. Archana Basair ma'am for giving me the opportunity and making me a part of this prestigious platform. Thank you so much, ma'am. And
Thank you,
best
Achal. Thank you so much for joining in.
Thank you, ma'am. And ma'am, best wishes for success in the upcoming elections. And
Thank
we
you.
are all with you, ma'am. My regards to Archana ma'am, Dr. Asha Bakshi ma'am, Dr. Shivani ma'am, Dr. Alka ma'am, Dr. Rakhi ma'am, Dr. Puneet Arora ma'am, Dr. Prajpala ma'am, Dr. Kalyani, who is a good friend. And thank you, Dr. Rudri. I feel so privileged to moderate a panel that is star-studded with very learned and well-experienced panelists, some of whom I personally know. Dr. Aswati, who is a dear friend, and Dr. Sharu Mohote ma'am. She is also a very knowledgeable dear friend. So today's panel is all about navigating the difficult and dark path of recurrent pregnancy loss and helping and leading our patients towards the light of motherhood. So may I invite our esteemed panelists and to a very informative discussion that will help us and our patients. May I share the slides?
Yes, ma'am, you can.
The stories that end badly are sad, and sadder still are the ones that never began. The loss of a pregnancy at any stage can be a devastating experience, and sensitivity is required in assessing and counseling such couples. So, as clinicians, we all have faced a patient coming with a history of recurrent pregnancy loss, and it's extremely painful to lose a pregnancy one had, than not having it in the first place. And it is equally frustrating for the treating clinician as well. So today's panel is all about solving the mysteries of RPL and finding the path leading to a successful outcome of a term live birth, because that is our aim. So we begin the case discussion, but just a brief introduction about the RPL and very informative and excellent talk by Dr. Shivani ma'am and Dr. Archana ma'am, and so beautifully the definition, everything has been already covered by Shivani ma'am. So I'll just skip the definitions. Um, We are all aware of the definitions of RPL given by the different regions and the different organizations. And the key elements would be it comprises the number of losses, that is the 2 or more losses. Then it can be consecutive or non-consecutive. And they include the biochemical losses, resolved and treated pregnancy of unknown location, and ultrasound that is done after complete expulsion of the embryo. Gestational age, the loss at some places it is 24 weeks, at some places it is mentioned as 20 weeks, and it typically excludes the ectopic and molar pregnancies as well as implantation failures. So these are the various definitions and the various categories. What are the types of RPL? So we are all aware about the primary RPL, then the secondary RPL and the tertiary RPL. So now I would like to ask my panelists, after how many losses do we investigate in clinical practice? Anyone can answer. This question is open. Anyone would like to answer?
After at least 2 losses, we should start investigating.
Yes, Dr. Dharna, very rightly said. Definitely, we should start investigating after 2 losses, and depending on the patient's age also and desire. In case the patient is more than 35 years, then we may start thinking after the first loss. But yes, after the second loss, definitely.
And if you have a second trimester miscarriage also, it's wiser to start after a first miscarriage only.
Yes, yes, Dr. Siddhi. Anyone
Dr.
else?
Parth, Dr.
Yeah,
Parth,
also
sir.
it's
Yes, please continue. Please continue.
Yeah, so regarding the losses, again, there is a different, different guidelines which has given different or ideas. Like there are, like in some guidelines, it is mentioned it is after 2 consecutive losses. And in
Yes.
Asia, it is mentioned even if it is non-consecutive losses, after 2 abortions, you should investigate. And again, there is a dilemma whether we should consider a biochemical pregnancy as a recurrent pregnancy loss or only a clinical pregnancy. But like in a clinical practice, as Dr. Archer said, it should be individualized. And after 2 abortions, considering the age of the patient and what initial treatment they have pursued, accordingly, we can start doing individualization and starting treatment.
Yes, very rightly said, ma'am. Coming to the risk factors have already very beautifully been covered by Dr. Shivani ma'am. So just highlighting that the advanced maternal age is the biggest risk factor, and therefore with increasing age, the risk of recurrent miscarriage keeps on increasing. I'll skip the risk factors because they'll be covered during the discussion of the cases. So what are the common reasons for the first and second trimester losses?
For the first trimester losses, it is generally genetic abnormalities or chromosomal abnormalities. Second trimester could be because of infections, uterine malformations, or uterine abnormalities, mainly cervical incompetence.
Yes. Very right, Dr. Richa. So as we see, the main focus, the main the cause is the advanced maternal age, and this is increasing in our society because of the delayed motherhood and delayed childbearing.
Dr. Mahima ma'am, if you'd like to add something into it.
Yeah, so primarily, when a patient with recurrent pregnancy losses comes to us, I think counseling is something which is very essential to tell the patient that, up to 50 to 70% losses occur due to the embryo being genetically abnormal, so this is something, a lot of times as IVF specialists, we get gynac cases, and the gynacs don't obstetricians don't send the fetal POCs for microarray, thinking that it's only the first loss. So I think even one loss can tell us a lot about the what exactly happened, because then that actually helps us IVF specialist or other gynacs also to be able to help the patient better. Also, as ma'am said, that it is due to advanced maternal age, and advanced maternal age also comes with its own set of problems like a thyroid dysfunction, prolactin, vitamin D deficiency, and anti-TPO antibody positive. So all those things should also be considered before we categorize the patient.
Exactly, ma'am. Dr. Indranil, sir, are you there? You want to put your opinion for this?
Yes, ma'am.
Sir, please put your opinion regarding this if you would like to add something.
Actually, mostly if we see uh, genetic abnormalities by and large, I actually encounter when I'm doing PGT. I am seeing that many aneuploidy cases are noted, and when we actually transfer a euploid embryo, then it gets actually implanted and it continues further. Regarding uterine anomalies or any other anomalies, actually we are prior aware of those anomalies and we try to correct it surgically. So maybe by and large, the undetected recurrent pregnancy loss may amount to chromosomal aberrations or genetic issues, is what I think, ma'am.
Okay.
Yes.
Can I add? This is
Yes.
Dr. Kritika. Yeah.
Sure, Dr. Kritika.
Yeah. As being in this IVF field for almost 2 decades, what I have observed is majority of the first trimester losses are due to genetic causes. So the problem can be either with the seed or the soil. So in first trimester, it is mostly the seed. And if there is a second trimester loss, look at the uterus more intently. So broadly, this is what I've observed.
Yes, very rightly said.
Yeah, second thing I would like to add 2 points here. The endometrium can be very selective or endometrium can be receptive. So there are two terminologies which was been founded by Nick McLeon, and he was of the opinion that if the embryo is euploid and then only it will get implanted. So the endometrium is very selective in that cases. But the endometrium can be receptive. So even that receptivity is too good where it will accept even aneuploid embryo. So this is first trimester miscarriage is more attributed to more receptive endometrium. So where later on it realizes that it's an aneuploid embryo and the pregnancy losses can be on the higher side. So many of the patients, when we see in our infertility practice, we get this patient of highly selective endometrium as unexplained infertility, because unless until they have euploid embryo, they won't be having chance of getting conceived. And we again see some patients where they are conceiving continuously, but they are facing this miscarriage like 1 or 2 times. So I feel a first trimester miscarriage, if it is attributed, then depending on the risk factor, we should advise them to go for genetic testing, particularly chromosomal microarray. Yeah.
Yes, very valid input, ma'am. So coming to our first case, she's a 30 years old, Mrs. ABC, married to Mr. XYZ, 35 years old, for the past 8 years, 5 years. And she's had 3 abortions. The first was a missed abortion at 6 weeks. Second was again a missed abortion at 7 weeks. And the third was a blighted ovum at 6 weeks. Her menstrual history is regular. Medical history, there is no abnormality there. Family history, nothing significant. Clinical findings, no abnormality. Hormonal profile was normal, APLA negative. The semen analysis of the husband was within normal limits. So this couple comes to you for an opinion and they have a long list of queries. What is the cause of repeated miscarriages? Is it because of her age? Can she successfully carry a pregnancy to term? Is it because of some infection? Which tests would be appropriate at this point? How long do we have to wait until we try again? What guidance would you offer before they try to conceive?
Ma'am,
Hello.
I would like to ask
Ma'am, regarding genetic workup, if I can say, first I will do parental whole exome sequencing to know any pathogenic sequence is coming from any of the parent. Secondly, actually, only PGT or only NICS is less sensitive, but combining both results will be better to know properly what is the status of embryo. And then after knowing the euploid status, I will suggest the uh, parents to actually go forward with the embryo transfer in these cases, ma'am.
And I would like to add to this.
Yes,
Let's
sure.
focus primarily on the evaluating the couple. It looks like unexplained at present. So the point Indranil mentioned, you should go for a proper karyotyping. Along with that, have a good 3D 4D sonography to evaluate the uterus, even the tubal part, and especially ovarian reserve, whether it falls into a diminished ovarian reserve category or a PCO. So you should get a good scan. Along with that, semen analysis at a good lab or at IVF center, at least 7 or 14 days apart, two samples. And along with that, I would like to add DNA fragmentation index, advice to the husband also. Uh, Another thing, slightly aggressive, but you can offer immunological testing of the wife if you can ultimately have a LIT therapy offered to the couple. And let's move to the treatment plan. Yes, definitely the difference can be made out with IVF with PGTA. And along with pickup, I would advise a diagnostic hysteroscopy to the female. If the embryos are blastocyst stage, reach blastocyst stage, then you can offer PGTA. And yes, you can definitely advise them LIT whether they opt or not. So this is the sort of management you can offer to this couple to have a live pregnancy reaching up to the 9 months.
Yeah, the first, can I add on, ma'am?
Yes, yes, sure.
Yeah, initially the first set of basic investigations has been done for the couple. As when they come for with a history of 3 abortions, the basic thing endocrinology part is ruled out, and most probably the 3D ultrasound is first what we look into. Though the history points out towards genetic cause more, but then first we need to evaluate the basic things like 3D ultrasound, rule out chronic endometritis. Probably hysteroscopy also will help us. Probably office hysteroscopy gives us a lot of information about the endometrium. But then after ruling out these basic things, then probably we may think peripheral karyotyping would help just to rule out, I mean, for the explanatory purpose, not like, I mean, if there are any translocations or reciprocal translocations, probably that can help, because whole exome sequencing is usually required whenever there is any history of second trimester, we see any anomalies in the baby, then probably then we may take a genetic counseling and then go for a whole exome sequencing. But in this case, if all the factors are basic evaluation is normal, then probably IVF and PGT should help in this cases after ruling out the other factors thoroughly. Can I add on, Dr. Anchal?
Yes, yes, sure, Dr. Asuti.
Yeah,
Go ahead.
so I think any couple who's going through this kind of scenario, basically, I would like to put down the causes or divide it into 4 basic causes that can happen. One is to do obviously with the embryo, and from the embryo side, we can go for in-depth evaluation of the sperms by a semen analysis and a sperm DFI. Oocyte, obviously, we don't have anything which is a foolproof measure of oocyte quality. Karyotyping for both husband and wife would help, a basic karyotyping. And of course, when we talk about the gametes, we have to incorporate lifestyle modifications, because there are certain things, and because addiction is quite common both in men and women these days. So all these factors also have to be looked into and corrected. Secondly, as the profile mentioned that APLA was negative, but there are other two, like we should do at least a basic thrombophilia screening, which includes anticardiolipin antibodies and beta 2 microglobulin, microprotein 1 levels as well. So and the studies mostly mention that you should have at least 2 reports which are 12 weeks apart.
So that should complete, and basic the history suggested that there was no medical problems. Otherwise, thyroid levels are something to be looked at. Diabetic status has to be looked at, and serum prolactin levels again needs to be measured, because that again could be a cause of RPL. As far as the uterine evaluation goes, the basic 3D ultrasound reveals quite a good amount of information, and hysteroscopy in SOS cases. Immunologically, I think immunological is something, a diagnosis of exclusion, which we have to think over. And what at the end of all the investigations, also, we have to tell the patient that 50% of these cases are idiopathic. We might not find anything. And usually, such patients, it is better to treat them with a blanket cover. For this couple, I wouldn't want to start with IVF. I mean, I would, of course, go with a basic evaluation. Wouldn't want to do an IVF straight away unless I find something very important or pertinent to the genetics, where I would want to do a PGT and identify the chromosomal normalcy of the embryo. I would still want them to try, because she's been conceiving, and give her a blanket cover with all the medications that we can go, I mean, individually treating all these causes, and sometimes even empirically, and then go ahead. So this is my
Yeah.
take on this.
Yeah, basically, when we are evaluating a couple, the important cornerstay of the treatment is going to be counseling and giving a emotional support to the couple. Because anyway, she was getting pregnant naturally also. So when it comes to IVF, there are going to be a lot of questions how we are going to go ahead. So, because we all aware that even if you transfer euploid embryo, still the success is around 70 to 75%. So whether we are giving them a guarantee that with all these things ruled out and transferring a euploid embryo, whether the chance of pregnancy and having a live birth rate is going to be very good, we can't do that. Then what are the other factors that needs to be counseled beforehand only? So regarding transferring the euploid embryo, that is one part of it. But then we should definitely ask them to give an option about uterine immunoprofiling and HLA tapping, because blanket LIT, like, we generally don't recommend unless until we have evidence where the uterine immunoprofiling is disturbed, or we have a evidence where the HLA tapping of the couple, there is more than 25% of the sharing is between the couple. Then it's better that if we want to go for IVF with PGTA, what else we should rule out? And again, the counseling also has to be important, that we get result of euploid, we get low mosaic and high mosaic. So in that also, we are going to transfer low mosaic. Then what is the outcome of that? And again, we have to go for, if we transfer a low mosaic embryo, then again, what could be the chances? So the counseling is going to be very important, because if we go for even PGTA with euploid transfer embryo and again she fails, and we have not counseled her about regarding other parts of what are the 25% other cause which is not going to give a live birth rate, I think it will be incomplete. So before embarking, I completely agree that counseling and a deeper evaluation of the couple and a psychological support is going to be a key before starting the treatment. And NGS for the couple, I'm really not in sync with immediately, because NGS is like a panorama box which is going to catch a lot of microdeletions and this thing, and which really we are not aware that what could be a pathogenic and which will be the reason of having abnormality in the embryo. So rather than that, either chromosome microarray or because the products of conception was not evaluated in this couple, then karyotyping will be good rather than going directly NGS for the couple.
Yeah, very rightly said, very true. So here, since all the tests were normal, so here the main focus would be on the genetic factors. And as we all know, trisomy contributes to 50% of all these pregnancy losses, where trisomy 16, 13, 18, and 21 are there. Monosomy contributes to 18%, triploidy to 17%, and mosaicism is there. So embryonic chromosomal abnormalities are there. Then we have parental chromosomal abnormalities. And these are the various guidelines which we have already discussed. So someone did mention, what is the role of parental karyotype in such patients?
Actually, ma'am,
As
sometimes the
You also
parental karyotyping, uh, actually, I don't mostly believe in parental karyotyping because it gives actually false notion that genetic composition is normal. So maybe if at all I would like, then I will go for whole exome sequencing. But in that we can have like pathogenic or likely pathogenic or unknown significance. Such kind of report can be seen, and then we can see if it is autosomal, sex linked, and accordingly we can counsel the patient. So I think rather than going for karyotyping, which will give us half-hearted information and false counseling to the patient, I will, in a view, go for a whole exome sequencing rather than parental karyotyping.
Ma'am, I slightly disagree because all of the abortions here were before 8 weeks, all of the losses. So most probable cause is genetic only. So if there are structural, translocations, balanced or Robertsonian, that may be detected by karyotype. So in this couple, karyotype is indicated. Because out of the RPL cases, 3 to 5% are because of parental translocations.
Yes. So,
Uh,
yes, Dr. Richa?
Ma'am, probably in this case, parental karyotyping, yes, it would give a better, it would help us in counseling the patient to rule out the translocation. So rather than whole exome sequencing, probably I would go for a first peripheral blood karyotyping, and then based on that, after detailed evaluation, then think of a whole exome sequencing.
Yes. So that is what ESRE recommends. It could be carried out after individual assessment of risk for the diagnostic purposes. So,
Dr. Rishabh, are you there? You want to add
to
something
risk
to
is,
it?
yes.
Dr. Rishabh, are you there? Okay. Anyone wants to add something to it?
Dr. Rishabh, Dr. Mahima is there? Dr.
Yes,
Pavitra?
I think I'm over here, if I may answer. Yeah, so I think a lot of counseling depends upon the current age of the couple. So if the couple is nearing 35 or more than 35 years of age, then I would want to personally counsel her for IVF to, shorten the time to pregnancy markup. And what we have to counsel them very effectively is to not to get pregnant before they are properly evaluated, because a lot of times these patients, because they don't have a difficulty in getting to that pregnancy, in getting pregnant, so they just feel it's not natural, to let's just tie in the next pregnancy. And a lot of times they come with to us with a beta hcg positive, or with a urine positive, and then our scope of treatment is very less. Of course, as Dr. Richa said, karyotype is something which is very basic, and to identify balanced translocations, that is a gold standard which we should be doing. Also, financial counseling when it comes to doing a whole exome sequencing for a couple versus doing an IVF PGTA. I think IVF PGTA will give us more answers than a whole exome, which a lot of times we have nothing much to tell to our couple as far as counseling is there.
Yeah, I agree with Dr. Mahima. Finances have to be taken into account
Yes.
because it's cost around 32 to 35,000 rupees per person from the couple. So I would rather go ahead with PGTA in that case rather than going ahead with the whole exome sequencing.
Yeah, can I just add a point here?
Yes,
Most
Dr.
of the couples' concern is if the karyotyping is normal for both of them, their question is when both of us are normal, how can our baby be abnormal? This is the commonest point of contention from the couple. So I usually tell my couple, like both of you individually may be normal, but when your gene and your wife's gene mix up, that's where the problem occurs.
Yes.
So this is something which we have to enlighten our patients.
Yes, very true. So the cytogenetic studies of the conceptors should be done always. What is the view of our panelists?
According to me, yes, definitely.
Second abortion should be
Onwards.
sent.
Second abortion onwards, it can be sent because it can give us a guideline if there is any underlying genetic issue. But again, it has its own fallacies. We have to remember that there could be maternal tissue contamination, or there could be otherwise contamination also. And one of the practical problems that I face with these patients are usually in the first trimester, early first trimester miscarriage, like less than 7 weeks. We prefer giving a medical abortion to the patient.
Yes.
And sometimes collection of the RPOCs becomes difficult in that scenario. So just to collect an RPOC, you are going ahead with a DNA. How warranted that is, that again is a question mark. So I would say at least the second abortion onwards, I would want to, seriously think of some genetic issue and evaluate. First, I don't think definitely it is needed. And also we have to understand that the sensitivity of the test is just close to 80%. So there are many false negatives also which you can encounter with this testing. So this testing says everything is normal, doesn't mean even the chromosomal microarray has this kind of sensitivity. So you can't take this test completely on face values. You still have a little question mark left whether it is absolutely the embryo was fine or there was some problem. So these things have to be understood.
Yes.
Very rightly
Out
mentioned,
of
ma'am.
all the genetic techniques, which one will you prefer for the
It's actually
cytogenetic?
chromosomal microarray single nucleotide polymorphism, and it usually comes with that strength of 750.
Yeah.
So chromosomal microarray is SNP 750. That's a test called.
Yes. So we've already discussed a part of this, the therapeutic interventions, like in the form of PGTA, IVF, and PGTA, that can be offered to such couples. Coming to our second case, Mrs. XYZ, she's been married for 6 years with no living children. She's had 3 abortions at 20 weeks, 18 weeks, and 16 weeks. Her HSG picture shows this. How will we proceed in such a case?
This is actually a bicarbonate uterus.
Yes.
So most probably we will go for hysteroscopic metroplasty in these cases. And we will also suggest the patient that mostly will keep on high progesterone support, and from start of second trimester onwards, we will ask them that you should actually have bed rest, not fully bed rest, but a restricted movement, because she is bound to have this. So after that, we can see how the progress of pregnancy is there, and then we can take a call what should be done further.
Does everyone agree with the hysteroscopic metroplasty for biconjugate uterus?
Yes. Ma'am, according
Not
to
for this particular.
guidelines, we have to do a 3D TVS first and confirm that it's a biconjugate uterus. And surgery is not recommended for biconjugate, but for septate.
So, Dr. Anchal, if we see the HSG picture, the HSG picture goes in favor of a biconjugate uterus, but you can never be 100% certain on an HSG.
Yes,
You have
that's
to go ahead with a diagnostic
yes, we have to
hysterolaparoscopy for
confirm
this
it.
patient.
We have
First, confirm it what it is, because sometimes even a septate uterus can give rise to this kind of scenario. And coming to most of the patients with biconjugate uterus, they conceive naturally and they don't have this problem. But one thing that you have to look at is there could be a component of cervical incompetence in these patients. So probably, I mean, if I talk about the management, once she gets pregnant, then probably empirical cerclage, cervical cerclage should help. This is my take. And of course, if you are going ahead with an IVF, then a single embryo transfer is mandated.
Yeah.
It's a wonderful suggestion by Dr. Nair. Go for a single embryo transfer, early cerclage, at least after NT plus NIPT or double marker. And I would like to continue progesterone, even ecosprin, and low molecular heparin the patient can afford. And along with that, you can have a early first trimester coverage of steroids too. And yes, you can definitely have a role of immunoglobulins if patient can afford. And yes, sequential color Doppler monitoring of the fetus throughout the pregnancy.
Yes. So, Sonu
Even, ma'am, interval laparoscopic cerclage can be tried because she is conceiving naturally.
Okay.
Ma'am, and one more thing, I want to elicit the history whether after circlage she has aborted. I mean, because she has aborted almost thrice at 18, 20, 24 weeks. If she has aborted even after circlage, then probably she is the candidate for metroplasty. Otherwise, just first try with the empirical circlage and then go ahead.
But for this particular patient
abdominal.
with the abnormal HSG, I think it is better to do a hysteroscopy than to straight away take her with empirical treatment. When there is an obvious cause and married for 6 years with 3 miscarriages mid-trimester, I think we are justified in doing a hysteroscopy first and then plan our next pregnancy.
Yeah, so that's what the guidelines say, that metroplasty is not recommended for bicorporeal uterus with normal cervix. And even for a hemiuterus, uterine reconstruction is not recommended. The only surgery that they recommend is for septum, uterine septum. And yes, later on, as our esteemed panelists have discussed, that in case things don't work out, then we may have to go for hysteroscopic for the metroplasty. What about T-shaped uterus?
So basically for T-shaped,
Hysteroscopy with cavity enhancement and metroplasty, yes.
basically the diagnosis of T-shaped uterus.
Sorry.
No problem. You can go ahead, please, Dr. Darshan. You can go ahead. Yeah.
I was just saying that not all T-shaped uterus require a lateral metroplasty. Sometimes we may do more harm than good in such cases.
Exactly, exactly. Dr. Sharayu, you were adding something to it?
Yeah. So basically, the diagnosis of T-shaped uterus has to be proper before going for metroplasty. So there is guideline recommendation which is given by ISHRE and a cornea classification that what should be the angle where we are taking at the cornea. It should be less than 55 degree. And it is not only that when we are entering with the hysteroscope, we are not able to see the ostia, then do lateral metroplasty. It is not the way. It has to be priorly counseled, priorly diagnosed, along with the guidelines and recommendations where all the 3 criteria of the corneal angle and the lateral angles fulfill. Then only we can ask the patient that this may help you if you go for metroplasty. But at the time when you are taking the patient for diagnostic hysteroscopy, previously you have done 3D ultrasound, but you never found a T-shaped cavity. Just don't go ahead with lateral metroplasty just because you feel at that particular time it is T-shaped uterus. Because I was attending one of the lecture from Dr. Nuzat, who is from Hyderabad, and she was mentioning that she this lateral metroplasty, she encountered 2 rupture uterus when the patient conceived after IVF and they went for lateral metroplasty. So overzealous lateral metroplasty is definitely not to be encountered. And first of all, if you are not doing it for the indicated cases, these patients are the one who are going to land up into thin endometrium and scanty menses if you are overzealously doing lateral metroplasty. So it has to be diagnosed properly on 3D ultrasound, then only we should.
Yes, I agree, definitely. A very good 3D ultrasound, but in cases of RPL with T-shaped uterus, hysteroscopic metroplasty is indicated.
Dr. Parth, you want to add something to it?
Yes, definitely, I'm in favor of doing a diagnostic histoscopy first. You can make out while performing histoscopy too. And if you found, along with the T-shaped cavity, if you find the endometrial quality is not that good, you can offer them even endometritis panel and all before making them pregnant again.
Okay.
So coming to our third case, a 35-year-old woman, regular menstrual history. Her obstetric history shows her first pregnancy resulted in a missed abortion at 8 weeks 3 years ago. Her second pregnancy resulted in an intrauterine fetal demise. And her sister has 2 children born preterm due to severe preeclampsia. On physical examination, everything is normal. Her 3D ultrasound is also normal. Hormonal evaluation, thyroid, prolactin are also normal. So what is the diagnosis of RPL in this patient? And how
She
will we...
is mostly a case of Apela syndrome. So
Yes.
maybe for these patients, we have to do the whole profile of beta 2 microglobulin, anticardiolipin antibody. And according to the weight, I am saying again, according to the weight, we have to give enoxaparin as a preventive measure, because sometimes for BMI less than 20, we are giving 40, they lose pregnancy before. And for some patients who have BMI more than 35, we are stick with enoxaparin 20 or 40, which is not helping. So accordingly, assessment of wholesome parameters and then giving the apt treatment with aspirin and enoxaparin may help. Secondly, it has been seen that there is some immunological role with these, as these are uh, antibodies which are causing. So in these cases, we can have immunological profile maybe by giving small amount of steroids. Maybe we can give immunoglobulin 16.5%, maybe intralipid weekly or fortnightly, or maybe we can give immunoglobulin infusion. So that may also sometimes help with this all parameters.
Yes, very correctly mentioned. And we have a whole the clinical criteria, lab criteria, and according to that, patient will be diagnosed as a case of Apler syndrome, and accordingly, we will start her treatment. What about hereditary thrombophilia? Should we screen the patient for hereditary thrombophilia or not?
Routinely not recommended. Only with
There is a
if we have additional risk factors, like if there's history of thromboembolism in previously in the patient, uh, severely obese, or some hereditary risk factors, then only we will assess.
Yes,
In
very
this patient, it can be thought of because her sister also had a similar history of severe preeclampsia. So we can at least consider investigating her. Not that we would always get something, but yes, we can consider because the sister had a significant history as well.
yes. So what therapeutic interventions, like we've already discussed, heparin and low dose aspirin. Anyone wants to add to what has already been discussed? What about homocysteine?
So, madam, in a lot of such cases, I have seen in my practice that they come out to be MTHFR gene mutation. Initially, 2 years back, I used to feel, why has the lab, done this MTHFR, which I don't have an answer to give to my patient. But yes, a lot of times they have a problem in folate metabolism. Their homocysteine levels are high, and empirically, like we just start low molecular weight heparin, we have a basis of starting low molecular weight heparin and also titrating it according to the body weight. As sir suggested, if the body weight is more, then we can think of doing 60 milligrams per day. And yes, these girls do have a high resistance in their uterine arteries, and they have a predisposition of preeclampsia, or dopplers are deranged. At around 16, 18 weeks, you will see deranged dopplers, mild symptoms of IUGR. So those things can be picked up earlier.
Actually, for a homocysteine positive or MTHFR positive patients, we should actually go for what we call it as quatrafolic acid, which actually gives free methyl groups, which actually decreases the levels of homocysteine. Those are available in various preparations like Foligno XT or like that. So either quadrafolic preparation is needed rather than giving folic acid, which will not suffice the free methyl groups to neutralize homocysteine levels in the patient's body.
Okay. So what is the value of immunological screening in the diagnosis of RPL? In this patient, someone had discussed regarding this. But in general, should we screen for these um, parameters?
no, not as a routine.
Immunological screening will be done as a last resort in case of unexplained RPL when we have thoroughly investigated the couple and we don't find any cause. That would be the last thing we are going to think, and that too immunological most commonly if they have a history of first trimester abortions. So after ruling out genetic causes, still she is aborting after we have transferred a euploid embryo and still she is aborting, then probably that's the time where immunological thorough screening is required.
Yes, and what
Maybe
about
you can combine this with the hysteroscopy, diagnostic hysteroscopy, where you are doing, in which you can go for minimal profile, in which you can do CD138, natural killer cell profile, BCL6, and this will give us an immunohistological score. If suppose that is too large, then we can go for proper immunotherapy with cluster differentiations and then sensitization it over multiple sittings. So maybe I do recommend that as now the IVF successes rates have become too much competitive, you can do a chronic endometritis with immunological panel during a histoscopy biopsy, and that would be recommended if we see we want to maximize the results in a given cycle.
I would have a different opinion here, Dr. Anchal. As far as immunology is concerned, I think no test is foolproof. So whatever test you do, they are non-specific. Even the natural killer cells level, the blood levels are different and the uterine levels are different. So in these patients, as I mentioned, that I would rather, consider it as the diagnosis of exclusion and keep it in mind in all the cases of RPL that I treat. And I would like to, supplement them with empirical Vislone in a very minimal dose, 5 to 10 milligrams, HCQS, hydroxychloroquine, which is again an immunomodulator. And where I suspect there is a strong immunological base, I would consider giving intralipids to them. So rather than going behind the investigations, I would rather treat them empirically and cover all the loopholes as much as possible. This is my take on it.
Yes, very rightly said, Dr. Aswati. When would you like to start HCQs?
So HCQ is actually all these immunomodulators technically have to be started before the month that you're actually contemplating a pregnancy. And they say that there's no specified duration where it is to be given. But I would suggest that you start at least 4 to 6 weeks prior to when you are actually starting. So, at least you give that much of immunosuppression. But yes, I would like to start on very low dose steroids because hydroxychloroquine, to my understanding, does not cause so much of an immunosuppression. It just modulates your immune system, but you have to be little, wiser when you start Vislone, and especially when you are giving a dose of around 10 milligrams per day. You have to rule out other things like her baseline blood pressure has to be normal, her sugars have to be normal, because you don't want to push the patient into a pro-diabetic state, or push the patient into a hypertensive state because of a long-term steroid. But usually around 4 to 6 weeks should be the time when they should be started to have a good response.
I would agree with Dr. Nair, and she's talking about cocktail therapy. So, along with intralipids and Visolone, I'll also prefer Barglob or Instaglob, and they all should be continued till first trimester at least.
Okay. What about lymphocyte immunization therapy in patients of unexplained RPL?
It is still experimental, so
The thing is that it should not be blanketly given. It should be individualized. That is the key. Every RPL case doesn't hold, for LIT. It definitely should be individualized, and it should be decided on a case-to-case basis whether a donor LIT would work, whether a husband's LIT would work. So it is case-to-base individualization always, depending on the profile, depending on the antibody titer of husband, so many things to decide about LIT. Kritika
I
ma'am,
think
you want to
before
add something? Kritika ma'am?
before
Yes.
yes, because a lot of patients nowadays do Google search on their own, and I have had patients who ask me about all this. Please give me this, please give me that. But I think it is a responsibility as a clinician that we have to emphasize all these therapies are still in experimental stage and not proven.
True. I think that these are the patients where we consider extra testing like HLA, and then we decide whether we want to give the LIT therapy or not.
Correct, correct.
But still, as a clinician, I would still, if a euploid embryo transfer has failed, probably 2 to 3 times, that is when I would consider a lit therapy, and not in the, in the initial, like if a euploid embryo has failed once, then we might do an ERA and so many other things to do. And I think lit therapy would be my last resort when I have no answers to give to the patient, to be very frank.
Exactly, ma'am. When there are at least 2 to 3 euploid embryo, single embryo transfer failures are there, then we should jump to these therapies. That is absolutely well said.
And is everyone
And
getting
that,
IVIG?
and very few cases require LIT therapy where once we have done the HLA typing and probably the cross matching of the alleles are more than 4 or 5 in husband and wife, and then we are going to check the HLA C1 and C2 and based on the key typing. So based on that, very few people at the end of the day when we get the HLA typing report, hardly 1% of the population require LIT. So rather than that 2 to 3 euploid transfer failure, then probably that is the case we can think of giving donor LIT.
True.
So these are the various recommendations for the patients of unexplained RPL. And all these things have to be individualized for patients' benefit. They can't be routinely given to every patient.
Actually, ma'am, I just request you to quickly summarize because we are
Yes.
running short of time. Yes, ma'am.
So just to conclude, this is a summary of the diagnostic tests and treatments of RPL. We all know that recurrent pregnancy loss is a complex condition requiring consideration of multiple factors for the appropriate workup and management, and the decision to intervene depends on the benefit to risk ratio of the proposed treatment. It can't be generalized for each and every patient. So it's important that all the couples are offered referrals to the centers or the clinicians who have specific expertise in the management, because I'm sure LIT not everyone is doing in case a patient needs it. So as in when the patient comes, every protocol has to be individualized. And having said this, lifestyle modification has its own importance, and we have to tell the patient that smoking and the cessation of smoking, then a normal BMI has to be there, then they have to stop alcohol, then the stress that is associated with RPL. And though stress in today's life can't be avoided completely, but then it can be minimized. And then decreasing caffeine intake. So all these things, and history taking, everything. The treatment begins when we meet the patient during history taking, and side by side counseling also begins. The couple should be dealt together. It requires a sympathetic approach, and cause is not found in 50% of the cases. Even after extensive investigation, they are unexplained. And chromosomal abnormalities are the most common cause, but they are usually sporadic in nature. So pre-pregnancy follow-up and treatment must be stressed upon. Thus, repeated counseling, support, and provision of psychological care is an integral part of treating such patients. And tender loving care, TLC, is one of the most important things. At every step of the way, we have to hold their hand, we have to console them, and we have to give them hope that there is light on the other side of this darkness. So thank you so much. And it was thank you to all the very knowledgeable panelists, very learned panelists. And we hope that
Thank you, ma'am. Thank you. It was very, very wonderfully moderated panel. And thank you, really thankful to you and all the panelists. Now, I just request all of us to, switch on the camera so that we can have a group photo that we usually always do at the end of this Fertilogix webinar. So I just request every panelist to just switch on their camera for a moment for a group selfie.
Dr. Anchal, it was a wonderful compilation of data, the evidence. Thank you so much. You have done a great job. I wish I could go through the entire slides what you had.
Yeah, excellent panel discussion, Dr. Anchal.
Thank you, everyone. Thank you so much. And
thank you, Dr.
Thank you, everyone,
Thank you,
for
everyone.
joining this
Thank you,
MP
ma'am.
chapter
thank you, Brajbala
webinar.
ma'am. Thank you, ma'am. Thank you, Archana
Thank you,
ma'am.
ma'am.
Thanks, Dr.
Thank you
Anchal.
so
And
much, ma'am.
lastly, I request everyone kindly support Dr. Archana Basair, madam. She is right candidate for President Foxy, and please convey this message in your society as well. So this is my humble request. Thank you so much.
Thank you.
Bye.
Thank you.
Bye.
Thank
Thank
you,
you,
everyone.
everyone.
Bye.
Shruti, can we end the meeting now?
Yes, ma'am, we can. From on behalf of the entire team at Universal NutriScience, I would like to thank all of you for being a part of such an interactive session. This was the fifth one in the series, and we conducted it very beautifully. It was quite an engaging session, and lots of points to learn from all our speakers as well as moderators. Thank you for giving us the opportunity to provide you with the platform as well. I'm sorry I cannot switch on my camera as I'm on back on my way to home. But yeah, thank you so much, everyone. Wishing you a very good evening and a good night too. Thank you, everyone. Bye.
Thank you, Shruti,
Rishikesh
for
sir.
always being very, very
Yes,
quick
yes.
and very, very
No,
helpful. Thank you, Shruti, and thank you, whole
no
UNS
problem.
team. Thank you.
Thank you,
Thank you, ma'am.
everyone.
Thank you.
Thanks for the wonderful webinar. Thank you, Archana ma'am. Thank you, Balbala ma'am. Thank you, Dr. Rudri, and everyone. Have a wonderful evening ahead. Thanks. Yes. Jignesh bhai, you can end the meeting for all of us.
Yes, sir. Can I end now?
Yes, you can, please.